Welcome to The Explainer. Today, we're diving straight into a hidden and, frankly, deeply misunderstood medical mystery. We're looking at two distinct but highly overlapping conditions that can make everyday, ordinary sounds completely unbearable. So, can everyday sounds actually cause physical pain? Well, let's dive into this, because for so many people out there suffering in silence, the answer to that question is a debilitating yes. I mean, just imagine living in a world where the rustling of a newspaper, the clatter of silverware, or honestly, just someone talking to you at a normal volume triggers an intense, agonizing physical reaction. The symptoms are incredibly real, but here's the kicker. The underlying medical culprits are often entirely misidentified by both patients and doctors alike. Here is our roadmap for today's explainer. We'll start with when sound becomes painful, look at hyperacusis, which is the brain's amplifier, and examine TTTS, the muscle rebellion. Then we'll explore trigeminal and eustachian links, how we diagnose the invisible, and finally, integrated pathways to relief. Section 1. When sound becomes painful. To really understand the scale of this, think about this. A whopping 40% of people dealing with troublesome tinnitus also suffer from severe sound sensitivity. And it gets crazier, because around 50% of help-seeking tinnitus patients go on to develop secondary hyperacusis. This plunges them into this persistent state of auditory hypervigilance. They're constantly scanning their environment for noises that might cause them pain or spike their ringing ears. We're talking about a massive population suffering from what is essentially a broken acoustic filter. Section 2. Hyperacusis, the brain's amplifier. Now, you might hear the term central nervous system pathology and wonder what that actually means. Well, hyperacusis isn't generally a mechanical issue with your eardrum. It's actually a software issue. When your ear experiences even subclinical or hidden hearing loss, your brain realizes, hey, I'm not getting the normal amount of sound input from the environment. So to compensate, this process called homeostatic plasticity kicks in. The brain desperately tries to hear what it's missing by turning up its internal auditory gain. It over-amplifies the signals, so a perfectly normal sound enters the ear, but the brain processes it at a booming, overwhelming volume. And because the brain is just so complex, this over-amplification doesn't just show up in one single way. There are actually 4 distinct clinical subtypes of hyperacusis. First up is loudness, where moderate sounds are just perceived as way too loud. Then we have annoyance and fear. These are emotional subtypes where non-classical auditory pathways trigger intense negative reactions or sound avoidance behaviors in the brain's limbic system. But the absolute most severe is the 4th, pain, also known as noxacusis. In this subtype, the over-amplified sound actually triggers unmyelinated type 2 nociceptive pain pathways, meaning your brain literally converts those sound waves into actual physical pain signals. Section 3. TTS, the muscle rebellion. But what happens when the problem isn't the brain's software at all? The crucial point here is that tonic Tensor Tympani Syndrome, or TTTS, is a localized, somatic physical disorder. Inside your middle ear, there is this tiny little muscle called the tensor tympani. Normally, its job is to briefly contract to tighten the eardrum and protect your inner ear from really loud noises. But in TTTS, which is often driven by a sudden acoustic shock or chronic anxiety, this muscle just goes totally rogue. Its reflex threshold drops dramatically. It becomes hyperreactive, constantly contracting, fluttering, or chronically spasming just in anticipation of normal sounds. It basically acts like a flinching shield that absolutely refuses to relax. When we look at these two side by side, we can draw a pretty hard medical line. Hyperacusis? That's a neurological volume problem. It's central gain and homeostatic plasticity. TTST, on the other hand, is a localized muscle rebellion. It's somatic, physical, driven by hyperreactivity and physical spasms. But the real tragedy of these conditions is that they frequently overlap. A patient with hyperacusis feels pain from everyday sounds, which understandably creates intense anxiety, which in turn causes the tensor tympani muscle to chronically spasm. And that creates this devastating, self-feeding loop of severe symptoms. Section 4. Trigeminal and eustachian links. It's kind of wild to think that a microscopic ear muscle can cause such an incredible amount of agony, right? But it all comes down to its shared anatomy. The tensor tympanic is innervated by the trigeminal nerve. When the muscle spasms chronically, it irritates this nerve. And because the trigeminal nerves supply sensation to your entire face, this irritation refers sharp, stabbing pain right into your jaw, cheek, and neck. These are symptoms that completely mimic TMJ or dental issues. Furthermore, the muscle is physically coupled by a tendon to the tensor palatini, which controls the eustachian tube. So when the tensor tympani locks up, it prevents the eustachian tube from equalizing pressure, creating this suffocating, persistent sense of oral fullness or blockage. Section 5. Diagnosing the invisible. So how does this translate into a real, actionable diagnosis? Audiologists look for very distinct clinical markers to separate the software from the hardware. For hyperacusis, they measure loudness discomfort levels, or LDLs. In hyperacusis patients, these levels are uniformly reduced by 16 to 18 decibels across the frequency spectrum compared to the general population. But for TTS, because it's an actual muscle spasm, clinicians use long-duration tympanometry. They monitor the eardrum over time, searching for erratic, sawtooth-patterned pressure shifts. This physically proves that the tensor tympani is twitching and spasming in real time. Section 6. Integrated pathways to relief. Because the mechanisms are so intertwined, treating this requires a fully integrated pathway. Step 1 tackles the brain. Tinnitus retraining therapy and cognitive behavioral therapy help slowly expose the patient to low-level sounds, rewiring the brain's central gain and calming that fear response. Step 2 tackles the physical symptoms. Musculoskeletal physical therapy involves facial relaxation and neural tapping to release the muscle tension feeding the trigeminal nerve. Step 3 brings in neuropathic medications, like amitriptyline or pregabalin. These act like a chemical blanket to calm the hyperexcitable trigeminal nerve endings. And finally, Step 4 is strict for extreme refractory cases of TTTS, a surgical tenotomy, where the tensor tympani tendon is literally cut to stop the spasms permanently. So we leave off with this thought. Knowing whether your pain originates from the brain's internal amplifier, turning up the volume, or a localized ear muscle acting like a flinching shield changes absolutely everything about how you treat it. It really forces us to wonder, how much faster could thousands of patients heal if these distinct pathways were accurately diagnosed from the very beginning? Thank you so much for joining me for this explainer. Keep asking those big questions, and I'll see you next time.